James will talk about slides. Now, this is a general surgical trial that has a potentially plastic surgery outcome measure. Let's hear this.
Thanks very much. So thanks very much for inviting me down here. First of all, I would like to ask you guys, hands up if you operate on patients. Good. Keep your hands up if you use the scalpel. Okay, so what I'm going to talk to you about today directly impacts upon your surgical practice today and on Monday. So I really want you to listen hard, and I'm here for your help. Okay, that's blank intentionally because I don't like speaking with slides, but I do have some, so don't worry. I'm a general surgical trainee, and I've got a story to tell you first. Okay, it was only last year. I had to operate on a 12-year-old Crohn's boy, and me and my boss started the operation. He made the skin incision, and then he got called away. He went away for the rest of the day, didn't come back, and I was there shitting myself because this boy had lots of adhesions, lots of strictures. It was a very dangerous operation, and I was there with the SHO. But I was concentrated hard. I was really quite scared, but I managed to get through most of the operation. I was coping. I was really doing the best, and you'd be happy to know that the patient did really well afterwards. And I was coping throughout the whole operation until one point, and that was when I made a mistake. When I was extending the incision with the scalpel, I handed it back, and I pricked the scrub nurse with my scalpel. And I was completely mortified. Because she had to scrub out, she was really quite distressed. She spent the whole of the afternoon in occupational health. Another scrub nurse had to be scrambled, and she was not happy to come and join me to finish the operation. And I felt really quite bad about it all. And my mistake not only caused stress and anxiety, it cost money, because somebody had to deal with all that extra resource mobilization and also the monitoring of that scrub nurse. So, did you know actually that there are 12,000 scalpel-related sharps injuries in our operating theatres every year? So it's not an uncommon thing at all, and that was something I was quite surprised to find out later on. And can you imagine how many sick days that involves? Can you imagine how much stress and anxiety? Can you imagine how many lawsuits come out of that? Because there are a few, and that all costs money to the NHS as well. So anyway, back to my story. I sat down afterwards and I thought, is this just, have I done everything right? Was I just, because I used the receiver, it was just a momentary lapse of concentration? Or is there something else I could do? Well, the easy option would have been to just say, oh, let's carry on as they were. But I didn't. I decided I was going to try and do something about it. And then it came to me very quickly that actually the easiest way to stop these injuries happening in the operating theatre is to stop using the scalpel. We don't use it for anything else these days other than the skin. So that brought me straight to the next question. Is it okay to use something else to cut the skin? And for me, diathermy is the other thing that we use. So my question was that. And that's where I got stuck, because the literature is incomplete. It doesn't tell me once and for all. There have been 4 meta-analyses in the last 2 years asking this question, and practice has not changed. So, just to try and compare the outcomes, just to try and bring you through this and show you where the gaps are, why do people still use the scalpel? Well, there's infection, wound complications, pain and cosmesis. People believe that maybe it's better for that. Other people have looked at speed and blood loss of the incision. And you'll be glad to know on a Friday afternoon I'm not going to then show you all those 4 meta-analyses. But I am going to take all the forest plots and put it on one page here. So on the left there favours diathermy, on the right favours scalpel. And for the first outcome measure, in 3,000 patients, in 4 meta-analyses, there is no difference between the 2 modalities. You see the diamond crosses the middle. For wound complications, that's also adding in dehiscence and all these things that are not necessarily infection, again, no difference. For pain, there seems to be maybe a little bit of a better pain score if you use diathermy in the first 24 hours. However, that diamond also just reaches the center point, so it's not statistically significant. Speed is actually quicker with diathermy by a little bit, because you don't have to stop and then to put the scalpel down and stop all the bleeding. Blood loss, as you might imagine, is less with diathermy. But there is a hole here and that is, so you can see the forest plots all sort of seem to favour diathermy, or at least are no better for the scalpel. But there is a hole, as I said, this cosmesis. There's only been 5 very small, methodologically flawed, randomised controlled trials to try and answer this, and none of the meta-analyses could even put this into their papers. If you take the largest randomised controlled trial on cosmetic outcome, you have to go all the way back to 1990. Dixon et al. Took 60 patients undergoing inguinal hernia and tried to measure the cosmetic outcome, randomising half to scalpel, half to diathermy. Their conclusion was that diathermy was better, but they only measured it at 6 weeks, and they used an unvalidated way to measure it. The only person who was blinded to the intervention was actually the nurse observer, but she also said that the diathermy moves were better. But again, it's only 6 weeks, and we know that scar remodelling happens for up to 18 months. So it really hasn't been answered, this question. It's very possible that diathermy is at least the same as the scalpel in terms of its outcomes. It may even be better in some aspects. Cosmesis is the final domino in this problem, and if we were to answer this question, might even see the end of the scalpel. If we could get rid of the scalpel off the set, that would mean that surgery would definitely be safer. Those 12,000 sharps injuries would come down. I'm not saying it would go all the way completely, but certainly reduce that quite considerably. And not only would it be safer, but it would be cheaper. You might be surprised to hear that we spend £1 million on scalpels every year in the NHS. And there's also all those costs associated with the sharps injuries that I've just already gone over. So the SLICE trial is not really just about diathermy versus scalpel, which one looks better. It's actually about improving surgical safety, and it's about saving money. And this research is actually really important for that reason. And that's why I'm here today, to ask you to join me to try and develop this together, because we need plastic surgeons on board with this, and to develop it, to get it funded, and to deliver it at a low cost. So this is the proposal. I'm going to go quicker through this. It's multi-centre, single-blind, non-inferiority, pragmatic, randomised control trial delivered by the trainee research collaboratives across the UK. The population would be adult laparotomies because this is standardised midline incision. It's done pretty much the same. And general surgeons, you probably agree with me, don't really care about the cosmetic outcome of their operations. The intervention would be diathermy for skin, and the comparator would be scalpel, and the outcome would be patient-reported scar outcome at 6 and 12 months. And the thing is that the intervention is something that trainees do all the time. It's not the consultants that open up the abdomen, it's me and it's my peers. And it's quite an easy thing for us to actually recruit patients into. This is the outcome measure, and this is the best job we've done at choosing something to outcome measure, but you guys might be able to tell me what is better to use. The post-AS scale has been validated, and it has been written up in some reviews as the best score so far to use, and it's the only one that's actually patient-reported. And the good thing about this is that patients can then do it at home by email or by post. You don't need to visit hospital, and that becomes quite a cheap way to follow up these patients. You can also introduce some PPI here, involving patients in actually doing helping with the trial by getting patient peers to telephone up patients who are not responding, and thereby adding a bit of extra je ne sais quoi to the whole thing. Sample size calculation, I won't explain it a lot, but the standardized deviation is 8 in most of the trials using post-SAS. Non-inferiority limit being 2.9, meaning that any difference between the scales of less than 3 we don't think is clinically significant, and that's based on previous studies. With those significant parallels and an inflation factor for within site correlation coefficient, don't ask me to explain that, because that was the statistician who told me, and I got an explanation and I've kind of forgotten about it. I could try and bumble my way through it, but anyway, you make it a bit bigger. And the sample size is 314, and that is 5 times bigger than the previous randomized controlled trial, so it's way bigger. It will blow it out of the water. This is the trial's team so far. There's an epidemiologist, a couple of surgeons, a professor on it, but we need plastic surgeons on here. And what I need is collaboration with you guys, collaboration with the Royal College of Surgeons, and we need a surgical trials unit on board before we go to a funding body and ask for some money. This is how I can see it being delivered. I think it will deliverable in 24 months. Because a lot of laparotomies come through, we could get 16 sites with 20 laparotomies each within 2 months. The cost, well, I think if we deliver it through the trainee network and the follow-up is, as I've just stated, I don't think it's going to be a lot of money. You could also add some whistles and bells and inflate that cost if you want. But I think it's important to just stick with the main question and try and answer that. So SLICE is about surgical safety. I think it would be a very good value for money. That £100,000 would be paid back within a year if people change their practice. And I really want these guys to help me with this, please.